So 25 to 30% of our newly diagnosed AML cases, they harbor a FLIT-III ITD mutation, and this confers a poor prognosis with high relapse rates. In recent years, the addition of FLIT-III inhibitors like midostaurin, sorafenib, gilteritinib to AML-based therapy has shown benefit. And so Quizartinib is a potent second generation or a type 2 FLIT-III inhibitor that has shown promising results as monotherapy in patients with relapsed refractory FLIT-III ITD mutated AML. The CONTINUE-1 is a randomized double-blind placebo-controlled phase 3 study of Quizartinib in combination with intensive chemo in newly diagnosed FLIT-III ITD mutated AML. In this study, a total of 539 patients were randomized in a 1-to-1 fashion. 268 patients were randomized to the Quizartinib arm and 271 to the placebo arm. During induction, patient received standard chemotherapy with the 7+3 regimen, followed by Quizartinib at a dose of 40 milligrams from days 8 to 21. During consolidation, patient received high-dose Ara-C, followed by Quizartinib from days 6 to 19, again for 14 days. And the patients could receive a total of 4 cycles of consolidation, followed by maintenance therapy for a total of 3 years. And the patients who proceeded to stem cell transplant started maintenance monotherapy after transplant recovery. As we can see, the median age of the patients in this clinical trial was 56 years and a median follow-up duration of 39 months. The primary endpoint of the study was overall survival, and at a median follow-up of approximately 40 months, a statistically significant improvement in the overall survival was noted here. As you see, the curves are separating between the Quizartinib arm at 31.9 months over the placebo arm, which was 15.1 months, with a hazard ratio of 0.78. The CR rate in both the groups was noted to be 55%. However, the median duration of CR was longer with the Quizartinib arm at 38.6 months versus 12.4 months in the placebo arm. In this study, the MRD negativity rate of less than 10 to the power minus 4 with Quizartinib and placebo were similar. However, if you look at the MRD undetectable rate, Quizartinib had a 14% MRD undetectable compared to placebo. 30% of the patients in the Quizartinib arm and 42% of the patients in the placebo arm relapsed. And here's the relapse-free survival, which again shows statistically significant improvement in the relapse-free survival with Quizartinib compared to placebo. It's 39.3 months versus 13.6 months, as noted here. Also, the cumulative incidence of relapse was lower in the Quizartinib arm. The most common grade 3 or high adverse event noted included febrile neutropenia, hypokalemia, and pneumonia. Neutropenia was most common adverse event with Quizartinib. QTc prolongation, which is a boxed warning with Quizartinib, was significantly higher in Quizartinib arm at 14% versus only 4% in the placebo arm. However, there were no cases of torsades noted in the trial. The 30 and 60-day mortality was also higher in the Quizartinib arm and was noted to be mostly because of infections. So on July 20, 2023, FDA approved Quizartinib in combination with chemotherapy and induction consolidation, as well as maintenance monotherapy in the FLIT-III ITD mutated newly diagnosed AML patients. And point to note is that this therapy, monotherapy Quizartinib, is not approved currently as a maintenance in the post-transplant setting. We are still waiting on more data on that. So combining FLIT-III inhibitors such as midostaurin in the RATIFY study and Quizartinib in the QUANTUM-1 study with intensive chemotherapy has clearly shown survival benefit in at least the younger patients in the frontline setting. However, the outcomes are still significantly poor in the older patients, where the standard of care is still HMA and venetoclax, where the expected median overall survival in this patient population is around 10 months. And in the relapse refractory setting, it's much poorer, around 2 to 6 months. So there's also preclinical evidence that suggests there's synergy between Quizartinib and venetoclax, hence the rationale for this particular clinical trial, which is a phase 1-2 study of Quizartinib used in combination with decitabine and venetoclax. The primary investigator, Dr. Yilmaz, presented this at ASH this past year. The primary objective of the study was to determine the recommended phase 2 dose of the Quizartinib, and secondary goals included response rates and survival. The study has two arms, with a relapse refractory arm as well as the frontline newly diagnosed FLIT-III ITD mutated arm, patients who are otherwise unfit for intensive chemotherapy. During the induction phase, patient received decitabine at 20 milligrams per meter square IV from days 1 to 10 during induction. And with the following cycles, the duration of decitabine was reduced to 5 days. Venetoclax was given at 400 milligrams per day from days 1 to 14, and then all patients underwent a bone marrow biopsy on day 14, and only patients with marrow blasts above 5% were allowed to continue venetoclax for up to 21 days. Quizartinib dose levels, there were two dose levels that were tested at 30 milligrams and 40 milligrams. Initially, the study included quizartinib to be given in a continuous fashion from day 1 to day 28. However, later on, the study was amended and the duration of quizartinib was reduced to 14 days during cycle 1 for our newly diagnosed patients. Here you can see the phase 1 data, where a total of 11 patients were treated. 9 patients received quizartinib at a dose of 30, and 2 patients received at a dose of 40 milligrams. At the 30 milligram dose level, all patients, 6 patients that were response evaluable, responded. There were no DLTs at this dose level. However, at the 40 milligram dose level, the 2 patients that were treated had grade 4 myelosuppression. Hence, the investigators decided to stop enrollment at the 40 milligram dose level and just continue with quizartinib at 30 as the recommended phase 2 dose. A total of 43 patients were enrolled in the relapse refractory arm, and the median age was 59 years. These were highly pre-treated patients, and the median prior lines of therapy was around 3. Approximately half of the patients received a prior HMA and venetoclax combination, as you can see here, and 83% of the patients received 1 or more prior FLIT-III inhibitor. Up to 74% of the patients were noted to have already had received gilteritinib. In the frontline setting, 14 patients were treated, and the median age was 70 years. 8 of the 14 patients had either therapy-related or prior HMA malignancy, such as MDS or CMML. These are the responses. In the relapse refractory arm, the composite CR rate was 65%, with a CR of around 12%. And by day 14, you can see here that 42% of the patients actually achieved morphological bone marrow remission, with an MRD negativity rate by flow and by FLIT-III PCR at 30% and 36%, respectively. In this multiply relapse refractory patient population, the 60-day mortality was 7%, and at least 40% of the patients bridged to allogeneic stem cell transplant. And if you look at the subgroup analysis that the investigators did with, in terms of prior exposure to gilteritinib, there appears to be no difference or impact on the response rates, and you can see it right here. However, patients with no prior HMA therapy demonstrated higher response rates. In the frontline cohort, all 14 patients responded. The CRC was 100%, and the CR rate was 79%. And remarkably, all 14 patients at day 14 achieved a bone marrow remission. There was only 1 death on the study in the frontline setting in the first 60 days of treatment, and 4 patients proceeded to stem cell transplant. So with a median follow-up of around 21 months, the relapse refractory cohort had a median overall survival of 7.5 months. Here is the subgroup analysis. In figure 1, you can see that patients who responded versus the patients who did not respond, the median overall survival was longer amongst the responders at 8.3 months versus 5.4 months in the non-responders. And within the responders, patients who displayed a CR had a prolonged overall survival of around 19 months compared to those who only achieved a CRI or an MLFS, which was 7 months. In figure 3 here, in terms of prior gilteritinib, you can see the prior gilteritinib exposure really did not make a statistically significant difference in survival. However, in patients with prior HMA-VEN versus no prior HMA-VEN, there was definitely a separation of the curves in favor of no prior HMA-VEN. With a median follow-up of 11 months, the median overall survival has not been reached in the frontline cohort. Febrile neutropenia remains the most common cause of grade 3 or higher non-hematological toxicity. It was seen in 42% of the patients, followed by pneumonia and other infections. Only one patient was seen to have a grade 3 QTc prolongation, and one noteworthy side effect in this regimen was prolonged count recovery, particularly in the frontline cohort. Of the first 6 of the 14 patients received Quizartinib for a total of around 28 days during the first cycle. All the patients responded. However, the median time to ANC and platelet count recovery was around 43 days, which is around 6 weeks. And then subsequently, they treated the remaining 8 patients with Quizartinib for only the first 14 days of cycle 1. Again, all patients achieved a CR, and the count recovery was reduced down to 36 days. So in conclusion, Quizartinib in combination with decitabine and venetoclax is active both in heavily pretreated as well as frontline FLIT-III ITD mutated AML. And this includes patients who also have received prior gilteritinib, where the overall survival remains 7 months, indicating meaningful activity even in this subset of patients. Now we'll be discussing about the menin inhibitors, and mainly we'll be talking about Syndax 5613, which is also known as revumenib, and then briefly we'll be discussing the J&J molecule. So formerly called as the MLL rearranged for mixed lineage leukemia, KMT2A rearrangement disease presents both in lymphoid and myeloid diseases, and it's seen in both children and adults, and approximately 10% of the acute leukemias harbor a KMT2A rearrangement. These leukemias are extremely challenging to treat because they have a high relapse rate after chemotherapy or even after transplant, and currently we have no approved therapies for patients with KMT2 rearranged disease. So here I'll be discussing the results of revumenib as a single agent in patients with relapse refractory KMT2A rearranged acute leukemia, the pivotal Augment 101 phase 2 study. Revumenib, or Syndax 5613, is a small molecule inhibitor of the menin KMT2A interaction, and it's being investigated currently in patients with relapse refractory KMT2A rearranged as well as NPM1 mutated acute leukemias, which are also known to be driven by the KMT2A menin interaction. Here are the phase 1 study results which showed that, and this was presented by Dr. Isa at ASH in 2022, demonstrating deep and durable responses with a manageable safety profile in heavily pretreated relapse refractory acute leukemias, with a CR/CRh of 30% and the median overall survival of 7 months. Augment 101 is a phase 2 study for KMT2 rearranged acute leukemias, enrolling patients as young as 30 days of age and with no upper limit. Patients received the drug at the recommended phase 2 dose of 160 milligrams q12 hours in combination with a strong CYP3A4 inhibitor. A planned pre-specified interim analysis of KMT2 rearranged was performed when 57 patients were centrally confirmed to have the rearrangement, and they completed at least 6 months of follow-up or discontinued therapy. The primary endpoint was CR plus CRh rate, and in this study, more than 10% in the CR/CRh rate, more than 10% in the adult evaluable population was considered the lower limit for anti-leukemic activity. The NPM1 mutant AML cohort continues to enroll patients and so was not included in this analysis. 94 patients were enrolled on the study and receiving at least one or more dose of revumenib at the recommended phase 2 dose and were included in the safety population. The efficacy population consisted of 57 patients, and these are patients who had at least 6 months of follow-up. The median age of these patients was 35 years, and 23% of the patients were under the age of 18. Patients were heavily pretreated, and 72% had received prior ven, and at least half of the patients had also received prior transplant. With a median follow-up of 6.1 months, in the efficacy population, the overall response rate was 63%. And you can see here the CR/CRh rate was 23%, and the primary endpoint of the study was met. The lower bound of the 95% confidence interval was 12.7, and it exceeded the null hypothesis of 10% for the anti-leukemic activity. 70% of these patients who had achieved a CR/CRh were MRD negative, with similar MRD negativity rates in patients who had achieved a CRc. The responses were durable, and 40% of the patients proceeded to stem cell transplant. The overall survival was 8 months at the time of this interim analysis. Febrile neutropenia, as in other studies, was the most frequent grade 3 or higher adverse event. Differentiation syndrome of grade 3 or higher was, however, seen in 16% of the cases and QTc prolongation in 14%. However, please note that no patients discontinued treatment due to differentiation syndrome, QTc prolongation, or cytopenias in this study. So in conclusion, revumenib is both safe and effective in KMT2A rearranged acute leukemias, showing durable responses with high MRD negativity rate, as well as high percent of patients proceeding to transplant. The study, however, was stopped early after meeting the primary endpoint of the predefined interim analysis. A new drug application for KMT2A rearranged leukemia has been initiated under the FDA RTOR program based on these data. So hopefully we'll be hearing soon on this drug. And then leading on from this, the encouraging results, MD Anderson is conducting a study, a phase 1-2 study investigating revumenib in combination with oral decitabine and venetoclax. They're trying to come up and see if an all-oral regimen is also effective. And this is the SAFE trial. Here we see the study design with revumenib, which was administered at two dose levels at 113 milligrams and at the recommended phase 2 of 163 in combination with Inqovi, which was for 5 days, and then venetoclax at the target dose of 400 milligrams for a total of 14 days. 9 patients have been enrolled in the study so far with a median age of 30 years, and 50% of these patients harbor a KMT2A rearrangement. These are, again, heavily pretreated patients, 3 median prior lines of therapy, and 50% have received prior ven or transplant. All 9 patients responded to treatment with a CR/CRh rate of 44%, and the CRs was observed in 3 patients, and all of these patients harbored a KMT2A rearrangement. The MRD negativity rate was 67. 5 of these patients proceeded to stem cell transplant, and at a median follow-up of 6.4 months, the relapse-free survival at 6 months is noted here to be 62%, and for overall survival, it's 71%. Febrile neutropenia continues to be the most common observed AE, and as well as the most common grade 3 or higher AE, with no severe differentiation syndrome or grade 3 or higher QTc prolongation noted as in the Augment study. In conclusion, early results of the all-oral SAFE study shows acceptable safety and high efficacy in patients with relapse refractory acute leukemia. Quickly talking about this another menin inhibitor, the JNJ-6617. This is currently being evaluated as well as part of the first in-human study in adult patients with KMT2A rearranged or NPM mutated relapse refractory acute leukemia. The study is currently in the dose escalation phase here using the Boyne statistical design. 86 patients have been enrolled in the study on either daily or BID dosing of the drug. They're all heavily pretreated with at least 3 prior lines of therapy. Majority of the patients that have been enrolled on the study are AML, and with an equal distribution of KMT2A and NPM1 mutation. The most common adverse event noted is differentiation syndrome with this drug at 12% of the cases, with at least 1 being grade 5. Of the 33 patients from these 86 that were evaluable for response, the overall response rate was 46%, with the CR/CRh and CRi rate of 27%. Currently, the study is still ongoing, and dose escalation is currently ongoing to identify the recommended phase 2 dose. And then very quickly, moving on to the last part of my talk, I would like to discuss the all-oral regimen of Inqovi or STEC-727, plus ven in the elderly unfit AML population. So this is a phase 2 study that was presented at ASH with a fully oral combination of STEX or oral decitabine plus venetoclax for the older unfit patient population. And this study enrolled 2 cohorts, a frontline cohort as well as a relapse refractory cohort. The frontline cohort had similar eligibility criteria as YLEA, as you can see here. And the primary objective of the study was overall response rate, with secondary objectives including survival, duration of response, and safety. The treatment consisted of Inqovi or STEX on days 1 to 5 and venetoclax on day 1 to 28, following a short ramp-up, and venetoclax was held if the blast cleared on the day 21 bone marrow. Consolidation cycles were also similar, consisting of 5 days of STEX with ven for 21 days. 62 patients have been enrolled in the study, with 49 being in the frontline cohort and 13 in the relapse refractory arm. And I would like to emphasize here, as you can see, that in the frontline cohort, this was a very high-risk population. The median age was 80 years. 24% of the patients actually had a complex karyotype. 80% were adverse risk by the ELN criteria, and 16% harbored a TP53 mutation. Importantly, 42% of the frontline cohort had a prior diagnosis of MDS or MPN, including 20% with prior HMA exposure or failure, which again portends a dismal prognosis. At a median follow-up of 18 months, 47 of these 49 patients in the frontline arm were evaluable for response, and all 13 patients in the relapse refractory arm were evaluable for response. The overall response rate was 64% in the frontline cohort and 46% in the relapse refractory arm, and the composite CR rate of 57% in the frontline and 46% in the relapse refractory arm. Of the patients responding with adequate samples, MRD negativity was achieved right here in 44% of the frontline arm and 20% in the relapse refractory. The 4 and 8 week mortality was 11% and 17% in the frontline and 0% in the relapse refractory. Again, it should be noted that the frontline cohort was composed of 20% treated secondary AML patients. The median overall survival was 11 months in the frontline cohort and 7.2 in the relapse refractory cohort. I would like to emphasize here that unlike the VIALE-A study, which did not include this high-risk population with prior exposure to HMA, upon excluding these high-risk patients from the analysis, the overall survival improved to 13.5 months, which was more in line or similar to the VIALE-A study. The median relapse-free survival was 12 months in the frontline cohort and 4.6 in the relapse refractory arm. The median duration of response was also durable in COVID-ven at 13.2 months in the frontline arm and 5.4 in the relapse refractory. And then most common grade 3 or higher adverse events, again, was neutropenic fever, pneumonia, and respiratory failure. Myelosuppression was common. And this was mitigated by dose reductions of ven in 50% of the patients, and 17% of the patients required at least dose reductions in both ven and in COVID. So in summary, STEX plus venetoclax is an effective and safe regimen in our older, unfit AML population, and upon excluding the patients with prior treatment of secondary AML in the frontline cohort, the rates of response and the overall survival are both comparable to the AZA plus ven in VIALE-A. So this combination offers the possibility of an effective fully oral regimen for chemotherapy-ineligible older AML patients and has the potential for less frequent hospital visits, shorter inpatient stay, and an improved quality of life. So with this, I'll be happy to take any questions.